One of the things that makes the practice of pediatrics unique is that we are privileged to travel along with families as children grow and develop. We'll sometimes meet a new patient in the newborn nursery and see them again and again as they become toddlers and then go to grade school. Maybe even we'll be there to help them prepare for college. And if the timing is right, we might even be there to see a second generation patient, a new baby whose parent had been our patient. It's wonderful. Along with watching children grow and change, we'll sometimes see how health concerns develop as a child grows. Sometimes one health problem that begins early can influence the development of problems later. And hopefully, if we can intervene early, we can even prevent later problems. That's really the goal of pediatrics, to keep our patients healthy by preventing disease. That's not always possible, but that's our goal. Let's meet Liam. He's a 3-month-old boy with a chief complaint of rash on face. That term, chief complaint, we haven't used it yet in this course, but it's an important part of a medical encounter. The chief complaint is usually stated in the patient's own words. It's the answer to the question, why did you come in today? Or what can I do for you? It's brief, and it focuses a medical encounter on exactly what a patient is worried about. Now, I said usually in a patient's own words. In pediatrics, some of our patients aren't talking yet. 3-month-old Liam may be very smart, but in this case, we're going to have to use a chief complaint from mom instead of the patient. Even though it was spoken by mom, we traditionally still call it the patient's chief complaint, and today it's rash on face. Liam has been in good health. He's growing and thriving, and there have been no prior medical concerns. He's exclusively breastfed, and he's up to date on his immunizations. He has an older brother who's now 5 years old, and the brother you know very well. He has a long history of many health visits with you for eczema, food allergies, and asthma. Let's go ahead to Liam's physical exam. He's happy and smiling, sitting propped up in mom's lap. 3-month-olds usually have developed what's called a social smile. When you smile at them, they'll smile back at you, showing off their big toothless grins. Liam certainly seems happy. On both of his cheeks, though, is a dry, red, scaly-looking rash. The rest of his exam is normal. The physical exam really is diagnostic here. This is eczema, a very common rash that often starts in infancy. In babies, it's often found on the cheeks. As kids get older, it's more commonly found in the folds of the elbows and the knees. It tends to be a very itchy rash, and I think the reason babies get it on their cheeks is that they feel itchy and rub their faces back and forth to scratch it. That worsens the rash. Eczema is sometimes called the itch that rashes. First comes itching, which causes scratching, which leads to skin breakdown and a rash. Mom says, yeah, I knew that's what it was. Robert, that's the older brother, she means, had that too. That's another unique feature of pediatrics. We don't just hear about a family history of disease, we sometimes see it ourselves unfolding in siblings. Eczema is also called atopic dermatitis, or sometimes atopic eczema. The word eczema comes from a Greek word meaning something thrown out by heat. And in past centuries, the word eczema was used for any warm or red skin eruption. And indeed, eczema is often red. Those other words that are sometimes used, like atopic eczema, here atopic refers to essentially a kind of allergy. Dermatitis, as in atopic dermatitis, is one of those itis words that means inflammation. In this case, inflammation of the derma, or skin. Already, we're seeing that simple and common eczema goes by multiple names. That's because our understanding of what it is and how to treat it has changed over the years. And it is common. In the developed world, about 20 to 30% of children have eczema. It's less common in the developing countries. We'll get back to why later. For now, what mom wants to know is, what's the best thing to do about it? The treatment of eczema should always start with good skin care. One of the fundamental problems in eczema is a breakdown of the skin's natural barrier function. The skin is supposed to stay intact and waterproof, keeping bacteria and toxins and pollutants out. But in eczema, the skin becomes cracked and inflamed. A topical moisturizer can do a great job restoring that barrier and keeping the skin healthy. There are a lot of moisturizers for sale, and some of them are very expensive, but really, most over-the-counter moisturizers do a good job. The best ones are simple, oily types of products with minimal added chemicals or stabilizers or preservatives, like plain petroleum jelly. Applied after a bath on top of wet skin, regular use of moisturizers can go a long way towards improving eczema, and mild eczema can often be treated with moisturizers alone. Mom knew all of that. She's been through this before with Robert, but it never hurts to repeat the instructions to make sure we're all on the same page. You also talk with Mom about using a topical anti-inflammatory medication if moisturizers alone don't work. For starters, over-the-counter hydrocortisone ointment is the mainstay medication, though there are many more potent products available by prescription if necessary. These medications are almost all in a class called steroids, which are modeled after our body's own built-in anti-inflammatory hormones. Our adrenal glands and other body tissues naturally make cortisol and other steroids, which, among other things, modulate our body's natural inflammatory response to injuries and infections. Topical steroids can act potently within the skin without exposing the rest of the body to the steroid effects. When used correctly, they're very safe and effective for all sorts of skin conditions, including eczema. Okay, same patient, Liam, but we're going to fast forward a few years. He's 2 now, and Mom has brought him in for a worsening of his rash. He stayed healthy overall, though his eczema had spread from his cheeks to his extremities. And over the last year, you've prescribed a stronger topical steroid that Mom has used intermittently. Now, the eczema is worse than ever, and it's time to think about some new approaches. On the exam, what you first notice is that Liam is not happy. He's itching, and you can see scratch marks on his arms and his legs over the eczema. Patches of eczema are really quite red today, and some areas look weepy and moist. What started as fairly mild eczema has become much worse. You start with the basics. Since eczema is in part related to damage to the skin, it's important that the family continue a good moisturizing routine. What to do about bath time is actually controversial. Some dermatologists don't like these kids to take frequent baths, and others do. But what is clear is that baths should be gentle, using lukewarm water rather than hot water, and that children shouldn't soak in soapy water. Let them play in plain water, then add a little soap, do a gentle scrub, rinse, get them out, and use a moisturizer afterwards. But there's more that needs to be done here. Often, the damaged skin associated with eczema allows bacteria, especially staph, to proliferate, and that can lead to more inflammation and more skin damage, perpetuating the cycle. It's not a good idea to use repeated courses of oral antibiotics. They have their own side effects, but what you should do in children with moderate to severe eczema is to monitor for infection and consider using weekly baths with diluted bleach to reduce bacterial carriage. Just a half cup or so of ordinary bleach in a whole bathtub of water makes a safe, low concentration bath with less chlorine than a typical swimming pool. We'll get Liam started on a diluted bleach bath routine and do a brief 7-day course of oral antibiotics this one time to help get things under control. It's also important to try to control the itching. As I said before, itching leads to scratching, which worsens the skin breakdown. And besides, itching is a miserable feeling, and it keeps kids and their parents awake. A nice, cool, wet compress can help a lot, sometimes along with an oral antihistamine. We'll also adjust Liam's topical anti-inflammatory medication regimen, stepping up to a stronger topical for a week or so, and then stepping back down the ladder to a less potent product as he improves. It's a balancing act that has to be individualized. You want to get the itch and inflammation under control using the safest and weakest topicals, but it doesn't make sense to use products that are too weak to get the job done. This is a case where regular follow-up with a pediatrician or dermatologist is essential, as is good parent education. We can give advice, but it's the parents on the front lines here. They need the knowledge and tools to take care of these problems themselves from day to day. There's one other aspect of eczema care to bring up. This can get a little murky and confusing, but for eczema that's more than mild or getting worse, it's worth exploring. We know that kids with eczema have a much higher chance of having food allergies, and that at least some eczema does seem to worsen when certain foods are ingested. The most common allergic trigger is probably eggs or cow's milk. What makes this difficult is that the kind of allergy that worsens eczema is usually slow to develop and manifest. This is not typically like the skin rash hives, which erupt very quickly when an allergic trigger is eaten. That would be easy to figure out. With eczema, if there's an allergic trigger, it may take days or maybe weeks to manifest. It's also frustrating that tests used to determine whether a food is an allergic trigger for eczema aren't very reliable. Kids can have, quote, positive food tests, but that doesn't always mean they're really allergic. Allergy testing, or a family history of foods that seem to parents to be a trigger, can be a starting point to try to narrow down a list of food candidates, but the only way to know if a food really is a culprit is to restrict certain foods, one by one, for several weeks, and see what happens. Then you have to reintroduce the food again to allow the child to eat it to see if eczema worsens. All of this takes time, and it's possible that there are multiple food triggers that make things even more difficult to nail down. Mom has already tried restricting eggs and milk. Her older son, Robert, is allergic to those anyway, so she's used to avoiding them. But she says that didn't help with Liam's rash. So we don't spend a whole lot of more time today focusing on allergic triggers. Instead, we work on the skin care regimen, prescribe an oral antibiotic and dilute bleach baths, and plan to see Liam again for regular follow-up and monitoring. And we do see Liam again sooner than expected. It's just a few weeks later, and Liam is here for follow-up of a different nature. He had been rushed to the emergency department 2 days ago after eating peanuts. Very soon after he ate them, he developed big red blotches over his entire body and started to cough. Mom, wisely, called 911, and the ambulance rushed him to the hospital. There, he was given epinephrine and IV fluids and did well. They kept him overnight for observation and sent him home the next day. Today, in your office, he seems to be doing well. His eczema, actually, looks a whole lot better now. Mom says, I just knew he shouldn't have had those peanuts. Your exam today is normal, and most of the encounter is about talking and teaching and making sure the family knows what to do. What happened to Liam was a severe and potentially life-threatening allergic reaction called anaphylaxis. That's, by definition, a serious reaction that occurs quickly after an exposure, often to a food or something like a bee sting. Usually, 2 or more organ systems are involved. The most common manifestations of anaphylaxis are in the skin, with the rapid appearance of large, raised, warm areas called urticaria, or hives. Liam also had coughing, which was probably caused by constriction in his lungs or throat. You explain to Mom that it's crucial that Liam avoid peanuts and that she have rescue medication available on hand always in case of an accidental ingestion and reaction. This medicine is called epinephrine, and it comes in a device that can automatically inject it into the body. You go over the instructions with Mom, when she should use it, and how she should use it. And you also talk with her about getting an allergist involved. Mom's got several good questions for you today, too. She wants to know, does her son Liam have to be allergy tested for peanuts? In a way, the answer is no. He already had the test. He ate the peanuts and had a very serious reaction, and so we know he is allergic. Still, there is a role for testing. It is a good idea to consider testing for what are called cross-reactive foods, in this case, tree nuts, which Liam might also be allergic to. Also, testing can quantify, in a way, the extent of his sensitivity, giving us a number to track. If over the years repeated testing shows a decreasing response, it would be reasonable to try to challenge him with peanuts in the future, though we'd only do that under controlled circumstances in a medical facility with epinephrine and oxygen and resuscitation equipment nearby. Mom also wants to know about the connection between the eczema and the food allergy. Her older son, Robert, had both too. Though he wasn't allergic to peanuts, he was allergic to other foods. Still, there is a connection here, and it's a growing area of research and knowledge. We know that people with a history of eczema have a markedly increased risk of food allergies, but we don't know yet how they're connected. Perhaps there's an underlying immune mechanism that increases the risk of both kinds of problems. Or, and this is what the latest research is showing, there may be a fundamental problem with the skin that predisposes to food allergy. We've known for a long time that when food allergy and eczema go together, the eczema usually comes first. Recent research has concentrated on a specific skin protein, filaggrin, which may be the key to unlocking the connection. Many children with eczema have a genetic defect in their filaggrin, leading to skin that's essentially leaky, allowing foreign proteins to be exposed to tissues underneath the skin. This can lead to allergic sensitization, which may then lead to food allergy. Even in children with normal filaggrin genes, inflammation or overgrowth of bacteria on the skin leads to inefficient filaggrin production. So either way, from genetic or environmental factors, filaggrin seems to be involved in the pathogenesis of eczema and maybe of food allergies too. Treatments for eczema, like moisturizers, topical steroids, and antibiotics, all improve filaggrin production and function. What we don't know definitively is if better treatment of eczema can really prevent the development of later food allergies. Now, that would be an exciting development, and one that pediatricians especially would welcome. Can food allergies be prevented? Other lines of evidence do show some tantalizing clues about that. For many years, we advised parents to avoid giving their children the foods that commonly caused allergies until they were older. This delayed introduction of things like peanuts, eggs, and grains was thought to prevent allergy. But it turns out that better studies have shown overall that the opposite is true. Earlier introduction of these foods may actually prevent allergic sensitization. Mom had said about Liam, "I knew he shouldn't have had those peanuts, but by delaying introduction of peanut, it may have actually increased his allergic risk." Current guidelines suggest introducing complementary foods, that means solids, to babies starting at 4 to 6 months of age without excluding or delaying any of them. Of course, parents still have to be mindful of choking. A small smear of peanut butter is fine, but a whole peanut would not be a good idea to give to a baby. Let's fast forward again. Liam is now 6 years old. He's had no further peanut exposures and now proudly wears a Medic Alert bracelet. No peanuts, it says. He's here today with a new problem, a chief complaint that he states himself. "My nose always itches and Mom says I have to stop rubbing it." On his exam, Liam's eczema is barely there now. It's gotten better and better over the last few years, and he only uses low-potency hydrocortisone now and then. But his nose is completely clogged and his eyes look pink and watery. Across the bridge of his nose is a horizontal line, a so-called allergic crease, that you can see why it's there. He keeps rubbing his nose upwards because it's so itchy. A new problem, I said, but maybe it isn't. What Liam has now is what's commonly known as hay fever. That's a terrible name because there's no fever and it's not usually caused by hay. So let's instead call it by its real name, allergic rhinitis. Allergic because it's caused by allergy, and rhinitis meaning inflammation of the nose. The allergies that trigger this are usually environmental ones, pollens and dust and mold, and you guessed it, allergic rhinitis is far more common in children who have a history of eczema and food allergies. We're starting to see a picture here, and it has a name, the allergic march. March here doesn't refer to the month of March, though it could actually, because spring pollens in March can be a potent trigger. The allergic march means a sort of parade, a march, with a patient sort of marching along as the scenery changes. Liam has marched from eczema to food allergy to allergic rhinitis. The treatment of allergic rhinitis starts with avoiding triggers, though that's not always easy. Many environmental triggers are found all over, indoors and out, and many people have multiple triggers, and it's not always practical to avoid them all. Still, some specific avoidance can help. For instance, if dust is a trigger, try to minimize stuffed animals and other dust collectors in bedrooms. If indoor mold is a problem, using a dehumidifier can suppress its growth, and a good quality air filter can help minimize exposures. This can be a good time for allergy testing, which can at least point some families towards the best avoidance strategies. There are some effective non-medical strategies too, like using saline sprays or washes to essentially rinse pollens and other allergy triggers out of the nose. But for most children, the most effective relief comes from allergy medication. One of the oldest of these is still in wide use, diphenhydramine, also called Benadryl. It's an antihistamine. It blocks the action of the chemical histamine, which is at the center of most allergic reactions. Though Benadryl works well, it's sedating. There are many newer antihistamines that are both less sedating and more long-lasting, making them easier to use. Another big category of allergy medications are topical nose sprays, which are, in many cases, the same topical steroids that are used in the treatment of eczema, just formulated to spray up the nose instead of rub onto the skin. Again, there's that common thread of these so-called atopic or allergic march diseases. In many cases, similar treatments overlap. Liam, he's not done yet with this allergic march. 2 more years passed, and he's here to see you with another concern. He's coughing a lot, especially at night, and especially after he runs and plays outside. Mom, who's been through this before, doesn't even wait for you to make the diagnosis. Don't tell me, she says. He's got asthma now, too. On Liam's physical exam, he looks comfortable and well. His eczema is gone. His allergic rhinitis is under good control, and he's got his Medic Alert peanut allergy bracelet on. What he also has, when you listen to his chest with your stethoscope, is a wheezing sound. That's what you hear when air is forced through airways that are shut down, small. It's kind of a whistly sort of sound. And that really is what asthma is, a reversible airway obstruction from tightening of the airways in the chest after certain triggers. The main symptom of asthma is cough. If you could look down into the airways, you'd see that during a flare-up of asthma, there's inflammation and mucus and debris down in the airways, which are narrow and constricted. Asthma is the last disease of the so-called atopic march, from eczema to food allergy to allergic rhinitis to finally asthma. Now, not all children who have some of these illnesses will develop all of them, but all of them are risk factors for each other. And atopic dermatitis, or eczema, is the common starting point. maybe again because of that leaky skin idea from damaged or poorly constructed skin filaggrin protein. The immune system is exposed through the skin to new allergens, becoming sensitized. That means the immune system essentially thinks that these allergens are the enemy and creates inflammation to fight it off. But these allergens, the peanuts and pollen, they're not the enemy. The body just thinks they are. In asthma, there are multiple triggers for symptom flares. Allergies can sometimes be a trigger, including the same allergens that trigger allergic rhinitis, but also non-allergic things like exercise or cold air or irritation from tobacco smoke. In asthma, the lungs can be thought of as twitchy or overly sensitive. They're ready to get inflamed, almost too ready, and all sorts of things can set them off. The treatment of asthma, you explained to Mom, starts, I think you probably expected me to say, it starts with avoiding the triggers, if possible. But we don't want to keep kids indoors avoiding exercise. That's not healthy either. In the long run, it's especially important for kids with asthma to keep exercising, to keep their lungs and hearts and bodies fit and in good shape. Most medications used to treat asthma are inhaled medicines that go straight into the lungs, coating the lining of the lungs where the inflammation is taking place. Many of the medicines for long-term control are steroids again, the exact same steroids that are used on the skin to treat eczema and on the lining of the nose with sprays to treat allergic rhinitis. Steroids are fantastic anti-inflammatory medications, and the topical forms, that is the creams and ointments and nose sprays and inhalers, are very poorly absorbed into the body. They cause minimal side effects and work very well. That's in contrast to the big shotgun approach of oral or systemic steroids like prednisone pills or shots. Those work great at stopping inflammation, but they have significant and lasting side effects and should be avoided unless absolutely necessary. People with asthma also depend on a second kind of inhaler, a quick relief rescue inhaler, using a different kind of medicine that's essentially a muscle relaxer. These medicines, the generic name is albuterol, relax the muscles around the breathing tubes, allowing them to expand. They work quickly and well, but they don't actually address the underlying inflammation. If used too frequently, they stop working. So for long-term relief, if asthma symptoms are persistent, a topical anti-inflammatory or steroid is the best option. There are a few other options for the treatment of at least some of these atopic diseases. Desensitization has been used for a long time for allergic rhinitis, most typically using injections of very small amounts of the allergen so the patient can develop tolerance. There's increasing research into using other kinds of regimens that avoid shots. One new approach expands this idea from allergic rhinitis to food allergies, specifically peanut, using very small amounts of ingested peanut protein. These kinds of approaches should only be done under a doctor's supervision, and they don't always work and can't always be done safely. But for some families, they show good promise to reduce the risks following a potential accidental ingestion. More research is needed before oral desensitization can be considered routine or standard of care. Overall, the rates of all of these atopic diseases have increased over the past few decades, especially in the developed world. This has led to the development of the so-called hygiene hypothesis, which states simply that an overly clean upbringing, free of exposures to allergens or with delayed exposures to allergens, might contribute to the development of allergic disease. This fits at least some observations. For instance, children raised on farms where there are plenty of animals and loads of pollen have fewer allergies than city kids. And we know that babies exposed to peanut butter early are less likely to become allergic. But there's a contradiction here. The hygiene hypothesis blames delayed exposures, and the allergic march model blames early exposures across damaged skin. Which is right? In part, they both are. Exposures via an intact normal gut and the normal ways that the immune system learns to tolerate, that is, to not react to allergens. At the same time, exposures across damaged skin might well do the opposite. I'll admit, it's complicated, and there's a whole lot about allergy and atopic diseases that we have yet to learn. For now, though, it's good to know that we do have effective ways to treat allergic rhinitis, eczema, and asthma, ways that can really help safely improve the quality of life. Hopefully, with more research, we'll get a better understanding of how and why these atopic diseases develop, so we can do a better job preventing them. Maybe that will end up helping Liam's little brother, who, you just found out, is expected to be born in about 6 months. That's another really fun aspect of pediatric care. Families grow, and our knowledge, hopefully, grows with them. Speaking of growing, what sorts of things do you think about if a child is growing slower than expected? There's a lot of possibilities, and it's up to us to narrow it down. See you next time. We've spoken a few times already in this course about what makes the practice of pediatrics different from other fields of medicine. Our patients are, in many ways, moving targets. They're not supposed to stay the same year after year. They grow, both physically and mentally, learning new skills and getting taller and heavier. If adults continued to grow at the same rate as children, we'd end up another 10 feet taller by the time we're ready to retire. All of that growing takes a lot of metabolic energy, which parents of especially teenagers know very well. It's fundamental to the health of children that they grow well. If they're not growing as expected, something has gone wrong. We've got a new patient in our practice today, Melissa. She goes by Mel. She's 12 years old, and her chief complaint that she tells the nurses at check-in is, quote, "My mom thinks I'm short." I like that chief complaint. It says a lot when you think about it. Mel is presumably short, but really, the way she worded it, she's not the one worried about it. It's her mom's concern. The quote is, "My mom thinks I'm short." That's driving the encounter. Mel and her family have moved here from out of state. There's really no past medical history, you're told. She fell from monkey bars last year and broke a wrist, but she has had no other emergency room visits, has never seen a specialist, and is taking no medications. Those are good questions to ask when meeting a new patient. Sometimes what you would have considered important past medical information can slip through the cracks if it's no longer on anyone's mind. For instance, maybe Mel had once been in a serious car accident with resulting brain trauma that could have injured her pituitary gland. By asking, "Have you ever been to the emergency department and have you ever seen a specialist?" you'll probably find out about anything that's really important from the past medical history, even if the child and parents had forgotten to mention it. What about reviewing past medical records? That's easier said than done. In this case, Mel's family forgot to bring them, which happens a lot. But even more vexing is when parents do bring the records, but they're too long or unreadable to be useful. A lot of us use computerized records now, which is great for some things, like recording a detailed note. But that same level of detail makes it difficult for a new doctor to review records efficiently. We often get past medical records on children. These are healthy children with nothing significant that are 300 printed pages long, page after page of, well, unimportant details that obscure anything possibly relevant. Past records printed from a computer are often, frankly, useless. One way around this would be to request, instead of the complete records, some kind of summary, maybe just a list of just the encounters and diagnoses. but not all electronic records can generate this kind of document. For me, ideally, what I'd like to see is a problem list, a list of current medications and drug allergies, a complete list of vaccines, and a set of growth charts. That is plenty. If I need more details, I can always ask. We don't have any old records today. Now, with the chief complaint about growth, old charts would have been useful, but lacking them, we'll ask Mel about what she thinks about her growth. She says she's always been the shortest in class, and since she hasn't started puberty yet, all of the other girls are just way taller than she is now. Her mom agrees, yes, she's just always been short, and our old pediatrician said it was nothing to worry about. We measure Mel and find that she's quite short at 54 inches. That's about the second percentile for height for a 12-year-old girl. That word, percentile, let's make sure we're on the same page with what it means. It is a statistical term used to judge the growth of children of any age and gender. The second percentile means, essentially, that if we were to find 100 girls of Mel's exact age and line them up by height, she would be number 2. 98 girls taller, 1 girl shorter. This is just a statistical construction. No one lines up 100 girls like this. And there are legitimate concerns that these charts do not account for racial differences. For instance, people of Asian heritage tend to be shorter than Northern Europeans. Still, percentiles are a good way to come up with a comparison and also to track children as they age. Whatever the percentile is, it really ought to track the same across the years of a child's growth. When someone is straying far away from an established percentile, let's say going from 50th to 10th to the second percentile, there may well be a medical problem. We plot Mel's other growth numbers too. Her weight is also at the second percentile at 66 pounds, and her BMI, the body mass index, is at about the 10th percentile. Mel is short and somewhat slender. Along with these numbers, you also look at her vital signs, her pulse and blood pressure and temperature and respiratory rate. They are all normal. So, what do you think? Mel is short, we've established that, but is she really shorter than expected? We know that short parents have short kids, so the next thing we need to do is to see if Mel is any shorter than she ought to be by comparing her height and expected adult height to what's called her mid-parental height. It's crucial to put our patient's height in the context of her parents' height. Mom, we learn, is 5 foot 3 inches tall, and Dad is 5 foot 8 inches tall. So both Mom and Dad are a little on the short side. To calculate Mel's expected adult height from these numbers, we first subtract 5 inches from her father's height. That's because, on average, women are 5 inches shorter than men. If Mel had a brother, his expected mid-parental height would be calculated by adding 5 inches to Mom. Dad corrects to 5 foot 3 inches, that's 5 inches less than 5 foot 8 inches, and averaging that with Mom's adult height of 5 foot 3 inches tall, we expect Mel to grow to be 5 foot 3 inches tall. By the way, I often actually measure those adult heights. Parents don't necessarily know their own heights, and I think sometimes they add a few inches, which isn't fair to their kids. We said Mel was at the second percentile for height. If we track that upwards, assuming she stays at the second percentile, she'll be 59 inches tall as an adult, or 4 foot 11. That doesn't compare very well with that adult predicted height of 5 foot 3 inches. Under most circumstances, kids grow up to be within an inch or two of that predicted mid-parental height. For Mel, we've calculated so far that she'll grow up to be 4 inches shorter than that. So we're starting to share Mom's concerns here. Mel is short, yes, but more concerning is that she's shorter than we expect her to be. Now, we'd really like those old growth charts. I'd be very curious to see if Mel has always been at the second percentile or if she's fallen lower on the charts as she's gotten older. Falling lower, that is, dropping to a lower percentile over time, makes it more likely that there's a medical condition causing growth problems. Let's think about what kinds of things might be going on before we move on to the physical exam. We'll need to know what kinds of things to look for, or we might not see them. Thinking about potential diagnoses might also give us some ideas about history questions we need to ask. We'll start with nutrition. Kids who don't get adequate nutrition won't grow well. Children need energy to grow, to build bones, and to build tissues, and that energy has to come from food. If there's not enough food, there's not enough growth. The pattern you'd see on the growth charts would be, first, a fall off in weight percentile. The child would get more slender. Then, over time, the height velocity would slow. That is, the rate of gain of height from year to year would drop, and the height percentile would fall. This wouldn't just happen in times of starvation or if a child didn't have access to quality foods. The same thing can happen in eating disorders when a person, for psychological reasons, restricts their intake. This is not as rare as you might think. In the United States, an estimated 30 million people have an eating disorder, including many who either restrict their eating or make themselves vomit afterwards. Most, but not all, are women or teenage girls. This is a very serious problem with a high mortality. Eating disorders, in fact, have a higher mortality than any other mental illness, up to 15 or 20%. We asked Mel about her eating and her weight, and she says she thinks she eats a lot or eats whenever she's hungry, and she's really not worried about it. She denies ever vomiting, and her mom agrees that Mel has always had a healthy appetite, and sometimes even eats more than her dad when they go to a favorite barbecue restaurant. Ribs, says Mel, I love those ribs. It does not seem like Mel has an eating disorder. Here's another scenario related to nutrition. A child can eat enough, ingesting plenty, but some conditions prevent the absorption of food nutrients through the gut. The most common of these so-called malabsorption syndromes is celiac disease, caused in susceptible people by the ingestion of gluten protein from wheat. Most, but not all, children with celiac have other symptoms like belly pain or diarrhea, and Mel denies any symptoms like that. Lacking any gut symptoms rules against all sorts of other GI conditions associated with poor growth, like Crohn's disease, celiac, or cystic fibrosis. Still, to definitively rule out celiac, we may end up doing a blood test. Beyond the gut and nutrition, another group of conditions that affects growth relate to the endocrine system, the chemical hormones that regulate many of the body's functions. There's the thyroid gland in the neck. Over or underactive thyroid functioning can slow growth in children. Mel, she didn't report other symptoms of thyroid dysfunction, like feeling cold or hot, or having diarrhea or constipation, or changes in her hair or skin. But still, let's keep that possibility in mind. Children's growth can also be slowed if there's insufficient growth hormone. That's not common, but it can happen. But at 12, I think the most important endocrine influences we need to think about concern puberty. During puberty, growth accelerates dramatically, and then it drops off and stops. If children enter puberty early, they'll shoot up in height, and they'll be taller than their peers for a year or two. But in early puberty means that the pubertal growth spurt will stop early, too. So these same kids who seem so tall end up stopping their growth when they're young, and they end up short. That girl who is mature, developed, and tall in the 5th grade, she'll stop growing soon, and other girls who start puberty later will pass her in height. Late puberty influences adult height too. It's sort of a tortoise and hare story. If you start early, you'll shoot ahead, but then you'll run out of steam. The slow tortoise doesn't get going until later, but keeps plodding along for a few more years. And net late bloomers will end up with a few more years to grow. Average growth before puberty is about 2 or 2.5 inches per year for both girls and boys. So a child who delayed puberty by 2 years could very well gain an extra 4 or 5 inches in adult height. I'm oversimplifying a bit here, but the bottom line is that if you want to judge whether a teen's height is as expected, you have to account for the timing of puberty. There are genetic conditions that affect adult height too, but these are more rare. The skeletal dysplasias, these are also known as conditions that cause dwarfism, they're rare, and long before age 12, we'd notice changes in the proportions of a child's bones leading to that diagnosis. Much more common is a genetic defect of chromosome number called Turner syndrome, which only affects girls. These girls are born with only one X chromosome instead of the usual 2 that most girls have. Lacking this second copy, girls with Turner syndrome are quite short. They have a delayed puberty or may not enter puberty at all and are at risk for other health problems involving the heart. Though some girls with Turner syndrome have a certain look to their face and body that makes doctors suspect the diagnosis early, it can be missed. We ought to test for Turner syndrome in any girl who is especially short or has delayed puberty if there's no other explanation. I think we've got a good list here so far. Nutrition and GI problems, hormonal conditions, things that affect the timing of puberty, and more rare genetic conditions. Let's proceed with our physical exam. Mel looks comfortable and well. We already saw her normal vital signs. Those weigh against thyroid disease, which often causes either a high or low pulse, and sometimes what's called a high pulse pressure, with a wide difference between the upper and lower numbers of the blood pressure. She doesn't have any other physical findings that suggest thyroid disease either, like a goiter, that's a mass in front of the neck from an enlarged thyroid, or unusually fast or sluggish reflexes. Her heart, lung, and belly exams are completely normal, and she appears to be entirely healthy and well proportioned. You also observe that she has not begun any pubertal development. She has no breast development at all. That's important to check because breast development is the first reliable sign of puberty in girls. There may also be acne and pubic hair, but these are more influenced by hormones from the adrenal glands than from the ovaries. With no breast development, we know Mel has not started puberty. Time for more questions. We ask Mom, were you early or late? When did you start puberty? Mom says she's not exactly sure when it started, but she does remember she got her first period in 8th grade, which seemed late to her, later than her friends. Puberty in girls starts with breast development, anywhere between age 9 and 14. That's been creeping back a little earlier, and many consider 8 to be normal now. It can even be earlier for girls of African American heritage. Menarche, that's the first period, typically occurs 2 to 2.5 years later and corresponds with slowing growth. By the time a girl has her first period, the maximum growth spurt is over. That Mom seemed to start a little late is reassuring. Perhaps Mel will follow that same pattern and is just destined to be a late bloomer too. We ask about Dad's history. He's not here today, but the timing of his puberty counts too. Unfortunately, men often don't recall when they hit puberty. Technically, male puberty begins with enlarging testicles at age 11 to 15, but men often have no idea when they did that. Instead, I like to ask, were you still growing at the end of high school or in college? Men who were still growing late had to have had a late start. Mom says she has no idea about Dad. We'll have to ask him, but that she doubts he would have had any idea either. And she's probably right. The remainder of the exam is entirely normal. In summary, Mel is an otherwise healthy 12-year-old girl who is slender and short. Her parents are short too, though not as short as Mel seems likely to be, and she may well end up being a late bloomer, which would predict maybe we're underestimating her adult height. There are no clues on the history and physical exam that point to any ominous or serious medical conditions. We explain this to the family, that we don't see any red flags to make us worry, though we'll want to watch her growth carefully, and we're going to want to see those old growth charts from her previous doc when Mom gets a chance to send those over. Can't you just call over there and ask for them? Mom asks. No, you say, that will have to be your job. There are privacy concerns here, and we can't just get medical records by asking. You need to ask the prior doc to send them to you or send them directly to us. So now Mel interrupts, how tall am I going to be? Am I going to be super short or what? That's a fair question, and to help get a better estimate, you suggest getting an X-ray called a bone age. We've been talking about the timing of puberty as key to knowing just how much growth is left, and a way to quantify that is by looking at her bones, in particular the bones of her left wrist. There are tables of data that look at these bones to see how much growth potential remains. And from that X-ray, we can get what is called a bone age. A bone age, in a way, tells you how old Mel's bones look. Do they look like those of a younger person, maybe a 9-year-old who has many years to grow? Or maybe like a 15-year-old who's nearing the end of her growth? Bone age films aren't 100% accurate, but they're a good way to help give Mel an honest answer to her question, to help pin down that number she wants to know. How tall am I going to be? We decide to do the X-ray, but hold off on other testing for a few months. We'll plan to recheck Mel in 4 months, see how her growth numbers look, and then decide if blood tests are needed to rule out celiac, endocrine disease, and the other possibilities we've mentioned. A few days later, Mel's bone age returns at 10.5 years, a little delayed, predicting that she'll be a late bloomer and predicting an adult height of 5 feet 1 inches. Still short, though taller than our earlier estimate of 4 foot 11. We still need to keep an eye on this girl. 4 months later, Mel comes back in for her recheck appointment. She looks a little more discouraged and is acting more quiet today. Mom says she's working very hard in school, but it's been a hard year and she's not doing as well as she thinks she should. That's okay, Mom says to Mel. I know you're working hard and you don't need to get straight A's. But Mel still looks down. A lot of kids put pressure on themselves to do perfectly, and that creates a lot of stress. You ask Mel about other things, and she says she's not sleeping well, she keeps waking up, and she feels tired a lot. Let's see what happened with our growth numbers. In the last 4 months, since you last saw her, her height increased by about ½ inch. That's a little less than expected for this age, and certainly not a gain that looks like she's going to start puberty soon. Far more concerning is her weight, which has dropped from 66 to 60 pounds. Now, Mom's surprised to hear that. She says Mel's been eating like crazy, eating and drinking all the time. Mom then offers you a big stack of paper, those old medical records, the ones you had asked about. Glancing through them, you see that 1 year ago, Mel weighed 62 pounds. So her weight had increased from 62 to 66 pounds at her first visit with you 4 months ago, but since then she's lost 6 pounds. That's a significant drop, and it is a new problem. Think back through the list we went through before. Does anything we mentioned fit? Mel still denies GI complaints of any kind. She's had no pain, no diarrhea, and no vomiting at all. She hasn't really overall felt sick, at least not until recently, when she started feeling tired a lot and not staying asleep well. You ask, what's waking you up at night? I have to pee like all the time, Mel says. It's crazy, but I just keep getting up. How about during the day, you ask? Yeah, Mel says, my friends make fun of me. They say I pee too much. It's like I'm always thirsty too. I have to keep drinking, so it makes me pee all the time. Now we've got a new clue, a clue that helps point us to one specific diagnosis. Mel has been losing weight since the last visit, and she's been thirsty all the time and urinating frequently. The diagnosis this suggests is diabetes mellitus to be precise, probably type 1 or juvenile diabetes. Now, I don't think she's had this for very long. Her symptoms and weight loss are new. though it's hard to pinpoint exactly when this started and how it could have affected her growth overall. It's possible, honestly, that this new potential diagnosis has really nothing at all to do with her overall height trajectory. Sometimes we just don't get 100% clear answers. You have Mel give a urine sample, and it tests positive for glucose, that's sugar in the urine, and that only happens when the blood sugar is very high. A quick fingerstick blood sugar is then done. A normal non-fasting blood sugar should be less than 140, and Mel's is 350. Now, Mel and her mom have heard about diabetes, and when you bring that up, they look scared, and Mom starts to cry. You don't want to be a fire hose of information here. Now, this family is going to have a lot to learn about diabetes and its management over the coming weeks, and you can't possibly teach it in a way that they'll remember all at once. But it's your job to get things started. Mel, you tell her, and you include Mom together while you're talking, facing them both. Mel, I think you have diabetes. More tests will be done to confirm this, but it really is the most likely thing. I know that can sound scary, but I want you to know there are great treatments for diabetes, and you will stay in school, and you will be with your friends, and stay healthy and strong. You're going to have to monitor things and take medicine, but you can feel good and stay healthy. I know you can do this, and I know Mom's going to help you too. They've got a few questions to start with. Mel wants to know, am I going to be short? You say, well, yeah, kind of. If you really wanted to be tall, you should have picked taller parents. That gets a little bit of a laugh. Mel says, I don't mind. It's okay to be short. I call myself fun-sized. Mom wants to know, what happens now? Does she have to get insulin or something? You say, yes, she probably will, but what I'm going to do now is call a specialist, an endocrinologist, who specializes in diabetes care. She'll be taking over, and she and her staff will do all the teaching and the helping. What about you? Asks Mel. Are you still my doctor? Sure, you say. You're stuck with me too. Diabetes comes from a Greek root word meaning siphon. It's been known since antiquity that people with diabetes make a lot of urine. The second word in the name, mellitus, means like honey, referring to the urine itself. It's sweet, and if left to dry out, a honey-like sugary residue is left. Diabetes is a simple enough disease to understand, though the ramifications and management strategies can be very complex. Sugar is an essential nutrient and an essential fuel source for the body's cells. And the amount of sugar, that is glucose, the kind of sugar that circulates in our blood, it's tightly regulated by a number of mechanisms. The hormone insulin plays a key role. It's secreted by the pancreas, a gland in the upper abdomen. Insulin serves to push glucose into the body's cells, lowering circulating blood glucose. In diabetes, blood glucose concentrations run too high because of insufficient insulin activity. There are two kinds of diabetes mellitus. Adults, especially obese adults, are prone to what is now called type 2 diabetes, where body tissues become resistant to the effects of insulin. The insulin is there, but it doesn't work. In type 1 diabetes, there is no insulin. The cells in the pancreas that are supposed to make the insulin die off, so there's no insulin at all. These two kinds of diabetes used to be called adult onset and juvenile onset, but that distinction has become less clear. More children than ever are now getting type 2 diabetes. That's mostly fueled by the rise in obesity. And it turns out that adults can get type 2 diabetes too. Diabetes in children, in the short run, causes excessive sugar in the urine, a lot of sugar, and enough to rob the body of needed calories, causing weight loss. Children will make a lot of urine as well, so they'll both urinate frequently and seem to be hungry all the time to make up for the lost calories. Sometimes children with diabetes can initially present in life-threatening crisis brought about by dehydration called diabetic ketoacidosis. Treatment will be lifelong. Mel will need to follow a healthy diet without a lot of simple carbs, and will have to monitor her blood sugar and give herself insulin by injection several times a day. That's not fun, but we know that with good therapy and good control of her blood sugar, she can lead a long, healthy life free of the complications of diabetes. And that's the real problem, those long-term complications like heart and kidney disease, blindness, strokes, and early death. Mom wanted to know at that first visit if Mel was too short. What we want to ensure is that she'll live a long and healthy life. We've been talking about growing too small, but is there a downside to growing too big? You bet there is. We'll learn more next time.